Hi everyone, my name is Sammy and I'm currently a first year psychiatry resident at Brookdale University based in Brooklyn. And so I want to welcome you all to How to Do CAP Research Workshop Series. It's a DEI initiative sponsored by ACAP, the American Academy of Child and Adolescent Psychiatry's Abraham Grant. This monthly series aims to address the barrier to entry into research by providing an overview of fundamental research skills and showcasing the diversity of individuals and as well as psychiatry and adolescent research topics and mentors. The series is directed to individuals at all career stages interested in child adolescent psychiatry research, interested in the incorporation of diversity, equity, and inclusivity principles into their research endeavors. So we hope to inspire individuals from diverse backgrounds and at all career stages to participate in research and explore ACAP resources. So throughout the series, we will feature different psychiatry researchers who will share their array of research topics and wisdom and introduce foundational research concepts such as how to get started in research, finding a mentor, developing a research idea, and finding funding support, as well as presenting and publishing your work. Each hour-long session will start with a research mentor sharing their career trajectory and using their own research to explain a foundational research concept. They will then close their discussion by sharing 5 overall pearls about engaging in child and adolescent psychiatry research. We will reserve the last 10 minutes for a Q&A, and during the session today, it will be recorded, so please feel free to enter questions into the chat, and I will help share these questions during the Q&A portion. You could also submit these questions anonymously by sending them as direct messages to me. So for today's session, we have the honor of inviting Dr. Jerome Taylor. Dr. Taylor is an assistant professor of psychiatry at the Perman School of Medicine at University of Pennsylvania and the first episode Psychosis program director at the Children's Hospital of Philadelphia. Dr. Taylor received his MD from the University of Virginia, completed an applied epidemiology fellowship at the Centers for Disease Control and Prevention, and graduated from Rice University with a bachelor's in biochemistry and cell biology. He completed his psychiatry residency and child and adolescent psychiatry fellowship at Yale, where he served as chief resident. At Yale, he conducted clinical research focusing on anxiety and obesity. Dr. Taylor is a child and adult psychiatrist interested in developing interventions to prevent schizophrenia and other illnesses with psychotic features. He is also interested in the biological mechanisms underlying the transition from being a youth at high risk for psychosis to a youth with a frank psychotic disorder. Particularly interested in the roles that neuroinflammation, oxidative stress, and sleep play in symptom progression to threshold psychosis. Dr. Taylor has received multiple awards and grants for his research, including the National Alliance for Research on Schizophrenia and Depression Young Investigator Grant, the American Academy of Child and Adolescent Psychiatry Pilot Research Award, and the American Psychiatric Association Substance Abuse and Mental Health Services Administration Minority Fellowship. Clinically, Dr. Taylor is committed to providing mental health care to under-resourced minority and LGBTQI communities. We are thrilled to have Dr. Taylor with us today. Thank you, Dr. Taylor. The floor is yours.
Thank you for such the very kind words and introduction. And I will share my slides now. I want to preface this by first saying that I'm really glad that it's a series. I'm the third in the series because I think depending on what type of research folks do, what type of mentors they've had, they will have different perspectives on research and how to well, really, what is success in research for them and how to be successful in research. So this is that's my caveat for this is my perspective based on my experiences and what my mentors have taught me. So with that caveat being said, I'm going to share my screen so you can see everything. And then I'm going to go into presentation mode for the PowerPoint presentation. All right, so my top, so yeah, and I can't see folks when I put it in presentation mode. So as Sammy said, you can put questions in the chat. Also, if things are unclear, you can interrupt me, and I will just when you do, if you do interrupt me, just make sure, ideally, if you feel comfortable, to turn on your camera. You don't have to though, and say your name. So, like, my name's Jerome Taylor. I am from the Children's Hospital of Philadelphia, and I'm an attending psychiatrist. So, just so I have a sense of where you are in training. Also, I think folks come at research from different perspectives or different levels. So, and if possible, it would be useful. Well, I'll keep it broad. But if there are any specific questions, feel free to put them in the chat. I'm fine to slow down, go faster. Just let me know, and I'll try to go pretty quickly through some of the stuff, just so we have about 20 minutes at the end for Q&A, and then I can go back through stuff. So I could talk about this for a long time. But all right, so my title of this presentation is Developing Psychosis Interventions, a Black Perspective. It took me a while to learn what ACAP actually stood for. So the way that I remembered it is that ACAP has triple A's, and the first A is silent. So it's the American Academy of Child and Adolescent Psychiatry. And the reason I say that is because I'll be showing some websites for ACAP. It has about like 10,000 plus members. It's a really great organization. It has been one of my organizational homes throughout my career development. Sarah Helwidge, who is on the call, who is on this call. I've never actually said her last name, so maybe I'm pronouncing it incorrectly. Has helped. I've seen her name on emails for over a decade, because ACAP really does help folks start and develop their careers. So with that, my email's here too. So if folks want to talk further, feel free to shoot me an email at taylorje@upenn.edu. It's taylorje@upenn.edu. And if I don't respond within a week or two, it means that just don't take it personally. It just means that I probably have a deadline that I'm working on or a clinical thing and missed your email. So just resend it. I appreciate reminder emails. So with that, next slide. I don't have any relevant disclosures or conflicts of interest. This is a picture of Ben Franklin, who established founded the University of Pennsylvania here in Philadelphia. And he, well, all of my checks have Penn on it, which is why he's there. And also the Children's Hospital of Philadelphia provides salary support for me too. And that's where I see patients clinically. So the 5 take-home points that I would have for you are, I want you to learn PICO, or PICOT, which stands for PICOT, Population, Intervention, Comparison, Outcome, and Time Course. So I'll just want you to remember that. It's how I think about intervention studies. And really, you can use it for non-intervention studies, but if you go through PICOT when you're describing any study, it'll be clear what you're talking about for the user, and make sure that you don't forget key, it helps me not to forget key details when I'm describing a study. So, and then I also hope that you come away from this presentation believing or convinced, or at least considering the idea that studying the early phases of psychosis may help us understand the biological mechanisms underlying schizophrenia. And there are 3 resources that I want folks to know about: jcap.org, reporter.nih.gov. JCAP stands for the Journal of the American Academy of Child and Adolescent Psychiatry. So the ACAP is the society. The society created its own journal. It's sometimes called the quote-unquote Orange Journal because the cover is orange. I have some over here, but they're great. jcap.org. And then reporter.nih.gov is a great website. It is useful to identify what at least government-funded NIH grants are going on at your university. So unlike kind of PubMed or Google Scholar, where you can see what's published recently, so that's completed work, Reported at NIH.gov is a great resource for identifying research that's currently happening at your institution, or at least a lot of research that's currently happening. So hopefully I'll be able to take you to some of, we'll have time to go to those sites. And then, you know, as Sammy said in my introduction, I've received funding from ACAP. I got the American Academy, the ACAP Pilot Award, which is a $15,000 award, which really helped. I'll show you some of the research that came from that. And it was really critical for me in my career development growth. And they also have travel awards, which will pay for you to travel to a conference. They're not, yeah, and sometimes they also provide mentoring opportunities and opportunities to present the travel award. So there are lots of different awards for early career psychiatrists and residents. So I will also take you to that website. In terms of my background, so I grew up in Atlanta, Georgia, which is the Black Mecca. This is me in the middle at my high school graduation. So the first 18 years of my life, I grew up in really an all-Black neighborhood. But for the last 20 plus years, I've been in predominantly white institutions. So I think culturally, I still learn new things about like non-Black cultures that I just didn't know. Yeah, so those institutions included the Rice University and the University of Virginia, where I went to med school, where I was a part of the Student National Medical Association, which was really useful for me both, which was key for me professionally. That's us on match day where I went into psychiatry. I hope if you're not already in psychiatry, this talk nudges you in that direction. And one of the key things that I do recommend for everyone in terms of their just development is, you know, taking a year out to focus on research. So during med school, I took a year after I finished my third year of medical school and went to the Center for Disease Control and Prevention and did an applied epidemiology fellowship back in my hometown of Atlanta. And it was super useful for me for two main reasons. One, I learned how to analyze data using SAS. And it doesn't have to be SAS. Any programming statistical language is probably useful. Like, I think that that's critical. If you really want to do research, you have to know how to understand data. At least clinical research. I don't know about basic science research. They probably don't learn programming languages like SAS. But the other thing I really learned there was how to write research papers. And if useful, I can share with you kind of the document that I still give to trainees and I still refer to sometimes when I'm thinking about how to write a paper. And kind of what I also learned there is shorter is better. Typically, the brevity is clarity. It takes a lot of work to be brief and clear. And then I did a year, and then I went to Yale and did training. So one important thing to understand as you progress throughout your trainings is there's typically a path for NIH-funded research. So I was in an integrated program that did adult psychiatry, which typically takes 4 years of training, and then child and adolescent psychiatry, which typically takes 2 years of training. And then I did T32 research in between, 2 years of T32 research in between. And then I did another year of T32 research when I moved here to the University of Pennsylvania to get expertise in schizophrenia research. And so typically the progression for folks who do research in residency is T stands for training. So usually and that's usually for postdoctoral fellows. So people who have already finished their MD or PhD or both. I haven't, sometimes I catch myself saying I just have an MD and not an MD PhD because there are many folks with MD PhDs. And T32s usually go to K awards, or the K classically stands for career development and awards. So it's T32 to K awards. And then ideally you make the jump to big independent grants where you're the PI, a couple $100,000 a year for, and PI stands for principal investigator. So that's the person who leads the study, wrote the grant for the study, and is ultimately responsible for completing the study and publishing the results. So T32, K award, And then R01, that's like the ideal trajectory. I finished my KL2 and I have a different private foundation award right now from the Robert Wood Johnson Foundation, Amos Award. So it's like a 4-year career development award. And I have yet to make the jump to R as like the next phase in maybe a few years. So as I said, I'm a child and adult psychiatrist. So I'm I do clinical research. And so I split my time between seeing patients in the clinic, which is about 30% of my time. And I also teach child and adolescent psychiatry fellows on their psychosis rotation. So all of the CHOP fellows rotate with me and in their second year of training or their final year of training. And then but most of my time is on the biological mechanisms of emerging psychosis. And I also co-founded and direct the first episode Psychosis program, and at the Children's Hospital of Philadelphia, where we do coordinated specialty care. It's really just it's the gold standard treatment for early psychosis or first episode psychosis. So just typically defined as psychosis with that has its threshold psychotic disorders that have had its onset within the past year or two. And really, it's just care that includes a psychiatrist, a therapist, someone who supports education and employment, and family support. So there's has to be family psychoeducation involved in it, and so that's the coordinated part of it. So coordinated specialty care, and it's funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, and so I think www.headsup-pa.org is a great site for all information in Pennsylvania, or you can. But there is also a national website, SMI Locator, but we can talk more about that later if you are interested. So what is psychosis? I said that I do psychosis research, treat teenagers with schizophrenia primarily, also bipolar I psychotic features, but I explain psychosis as when individuals have difficulty distinguishing between what's real and what's not real. So the classic question that all psychiatry residents, or at least child psychiatry fellows, learn is, do you ever feel like your mind is playing tricks on you? And the classic schizophrenia is like the prototypical disorder of psychosis. It's often considered the most severe form, and it occurs in about 1% of the population. Its onset is typically 15 to 30 years old, and it is characterized by hallucinations, which are any sensory, so it can be hearing things, feeling things, smelling things, without any stimuli actually being there. So classically, it's hearing voices or seeing kind of shadows or figures, and then delusions, which are false fixed beliefs. So like paranoia, the FBI is following me because I'm really special. So delusions. So that's what psychosis is at a threshold level, schizophrenia. And for me, I do it because it's sublimation for me. So sublimation in science is the transition of a substance directly from the solid to the gas state without passing through the liquid state. So an example of sublimation is the conversion of solid carbon dioxide or dry ice to carbon dioxide gas at negative 78.5 degrees Celsius. So that's what I learned sublimation was until I went to residency. And then I learned psychoanalytic sublimation is a mature coping mechanism, which is a term that is similar to defense mechanism. And it's when displacement serves a socially useful purpose. So I use the sadness of my best friend who developed schizophrenia as a motivation to develop interventions for schizophrenia. I think in research, everyone has to find their own. I think because research is really a career similar to medicine, you have to be motivated to do it. Different people have different motivations, but this is my motivation. That's why I changed from anxiety research and obesity research to schizophrenia research when I saw it from a personal perspective and not just patients on a psychiatric ward is very, very different. An organization that I strongly recommend to folks is NAMI.org. The National Alliance on Mental Illness. It has local chapters throughout the nation. It's also a great resource to give to patients where the information is solid because, teenagers, parents, they Google a lot of things. And NAMI is a source of good information, and a beautiful book that I always plug is No One Cares About Crazy People, My Family and the Heartbreak of Mental Illness in America by Ron Powers. I recommend folks read it. And then just the last thing is normalizing psychosis. So all of us can establish have psychosis symptoms briefly. So especially when we're stressed or tired, many of us, at least I can, think that we heard a knock at the door or felt our phone vibrate when there wasn't anything there. That is, our minds can play tricks on us. And that's the same thing that I tell teenagers and their parents about kind of reducing stress to minimize psychosis symptoms or to reduce psychosis symptoms. And so as an example of this, just the idea that you're going through the world and you're unsure what's real and what's not real. And remember, so the onset is 15 to 30. And which means that you go through most of your life, or maybe the first 15 years, thinking, seeing things normally. You can trust what your eyes see and what your ears hear. But then all of a sudden that changing. So what I want folks to do is, so they see this picture, could you just put in the chat if what color this dress is, if you see it as blue and black or white and gold, just put it in the chat. And I'll come back to it in about 10 minutes. I just am very curious what folks put in the chat. So is this dress blue and black or white and gold? And hopefully we have time to kind of go back to it. You know what? I'm just going to open the chat now and look at it and see. So blue and black, white and gold, blue and black, white and gold, white and gold, blue and black, white and gold. So pretty even split. So, to me, this dress is definitely white and gold. I don't see any blue and black. And so that means that I think that people who see this dress as blue and black are psychotic. Y'all are all psychotic. No. The truth is that this is an example of, and people who see it as blue and black, they really see it as blue and black. There's like no way they could see white and gold, maybe if they squint for most people, and vice versa. I have never seen blue and black in this dress, and still but it's dark blue, and they say it's navy blue and black. So I have to just believe them that they perceive the world very differently than me in this way. And this is just a simple example, but it happens for folks with psychosis on a regular basis for an hour, sometimes hours every day, most days of the week. So it gives me a lot of respect for them. I won't go into the diagnosis, but the main thing here is to diagnose schizophrenia, you have to have at least 6 months of symptoms, and there's a marked decline in functioning. So if someone is still making straight A's, I've never seen a patient with schizophrenia make not have a period where their grades dropped. I have patients now who their grades dropped and were sustained dropped before being treated with antipsychotics, and now they're back to making straight A's and are going to college. But they had to take a year or about a year, and they've recovered. Several patients like that, but there has to have been a decline in functioning without treatment, and the gold standard treatment is antipsychotics. Also, I just want folks to remember there are cognitive symptoms that occur with psychosis. And in fact, Emil Kraepelin, who initially described the disorder, called psychotic disorders dementia precox, because the cognitive symptoms can be pretty profound. And there are also negative symptoms, there are also negative symptoms which are things that were there, but you lose them, which is why they're called negative. So everyone has the ability to express emotion, and avolition is a word for amotivation, essentially. So and typically as motivation. So these teenagers grow up, or children grow up with the ability to express their emotion in terms of their affect, and also kind of they motivated, but they lose this, and that's incredibly disabling, and it's very difficult to treat. Which we use cognitive behavioral therapy for that in our coordinated specialty care program. And then, until 1971, autism and childhood onset schizophrenia were used interchangeably, because the social kind of the flat affect is also happens in autism. So impact of psychosis, over $150 billion a year, low rates of gainful employment, 10 to 40%. So but some people have, and this is before kind of coordinated specialty care really took off, which has been in the past year. But there is a high rate of mortality, and suicide is one of the biggest contributors to mortality. So about 5% of individuals with schizophrenia complete suicide, and usually it's in the earlier phases. So it can be very difficult illness to treat. It's important to remain aware of that. There are ACAP, as I said, practice parameters for it. And then now we're back to PICO, patients, interventions, comparisons, outcomes, time course. So the biggest study, and this is what I used an ACAP pilot grant to get, of teenagers with schizophrenia. So early onset is usually defined as onset of schizophrenia that happens before age 18. So the biggest randomized controlled trial looking at treatment of teenagers is called the Treatment of Early Onset Schizophrenia Spectrum Disorder Study, or TIAS. And so P for patients. So you had to have early onset schizophrenia, and you had to be ages 8 to 19 years old. They looked at 120 people. I for intervention. They randomized them to one of 3 different drugs, so risperidone, olanzapine, or melendone. The comparison, so they compared them to kind of one drug to the other drugs. There's no pill placebo group. And then so the outcome that they looked at was change in symptoms and improvement in functioning. And the time course was, so they were randomized to 8 weeks of treatment. So they looked at these outcomes after 8 weeks, so PICO. And they're the first line of treatments. And the reason I show this slide, so this is a secondary analysis that in part was paid for by the ACAP pilot grant. And so you look at, so on the x-axis, you have week of treatment. And on the y-axis, you have clinical response probability. So you're treating them with an antipsychotic, and the different colors are different medications. So red is melendone, green is olanzapine, blue is risperidone. And you see that maybe kind of melendone lags a little bit farther behind for the first month. Melendone is typically considered a first-generation antipsychotic. It's no longer produced, but it's weight neutral, which is why it was used, whereas olanzapine causes a lot of weight gain and risperidone causes intermediate weight gain. But as you see, over 8 weeks, they kind of all overlap. And one of the main findings of the study is it doesn't really matter in terms of how long it takes you to, it doesn't really matter which antipsychotic you use. The sad news is that only about 50% of folks ultimately respond to one of these gold standard treatments. And maybe olanzapine, so if you look at the median time that clinical response was achieved, it was 4 weeks for olanzapine, so maybe a little bit faster, 4.5 weeks for risperidone. So now I'm on the right side of the screen, and then 6 weeks for melendone. So maybe there's a slight difference, but it wasn't significant. And olanzapine causes much more weight gain. So on average, over 80% of the teenagers or children and teenagers in this study gained more than 7% of their baseline weight, which is so in 8 weeks, they shouldn't be gaining, they're growing, but they shouldn't be gaining more than 7% of their baseline weight that quickly. On olanzapine, the rate was lower for risperidone, about half of that. And then melendone, they didn't gain weight. So it was weight neutral. And the take home from that is that even though olanzapine may help folks respond a little bit quicker, it is not a first line medication. It is a second line medication because of its metabolic side effects. And it's not just weight gain, it also increases blood sugar and lipids. Y'all may know that already, but the point is antipsychotics are too late and too risky. And so my mission is clinical research to understand the mechanisms of psychosis in order to develop evidence-based and biologically targeted interventions for young people. So really, what causes psychotic disorders like schizophrenia? And we actually don't know for sure, but psychosis symptoms are seen in anti-NMDA encephalitis, which pioneering work here at UPenn was actually described. So that means that it's an autoimmune disease. They can have hallucinations that look like schizophrenia. Before they figured it, we used to call it neurosyphilis schizophrenia. Systemic lupus, SLE. Lupus can look like schizophrenia with lupus cerebritis, temporal lobe epilepsy. So can cause hallucinations. So we do know some specific causes of hallucinations and delusions, what we used to call schizophrenia, until we figured out the medical etiology, the biological mechanisms underlying them in the brain. But and so likely it's the schizophrenias. There's a saying, if you've seen one patient with schizophrenia, you've seen one patient with schizophrenia. Although they can be very different because it's really a syndrome. And unlike cancer, we can't cut it out to study it. So we can't cut out the brain to study it, obviously. And so still evidence suggests that circadian disruption, synaptic pruning is the essentially activity-dependent elimination of connections between neurons that occurs naturally during adolescence to make our brains more efficient. It's a normal process that happens throughout childhood. It's really important for brain development, but the belief is that this goes awry, and that leads to the onset of schizophrenia that has its onset in adolescence. So it's why you don't have schizophrenia as a kid, but you develop it later on. So that's where this hypothesis really originated from. And there's also evidence that oxidative stress and immune activation play a role in the onset of psychosis. So, when we think about heart disease, we have this idea that there's if you look at the right side, that that's a patent artery or blood vessel, and it narrows over time. And then it narrows to a point where you get no blood flowing through it, and that's when you get a stroke or a heart attack and so we know specific causes that contribute to this: high blood pressure, high cholesterol, smoking. And so my work is really to understand kind of the progression of psychosis. So just like that, I talked about schizophrenia, which is a threshold psychosis or a threshold psychotic disorder, and that includes first episode psychosis and more chronic schizophrenias. But there's also this syndrome called subthreshold psychosis or at risk. And that's when you have these symptoms, but instead of, an hour a day for most days of the week where you may hear symptoms, you may hear, Sarah, just once a week out of the blue, but Sarah, just happens. And it increases. We call that like clinical high risk for psychosis. It can also be, so they're not as severe as, someone talking to you constantly, but they are like, it can, for many patients, herald the onset of a schizophrenia. And about 20% of those develop, patients with kind of those subthreshold or maybe once weekly symptoms go on to develop schizophrenia, a threshold psychotic disorder, usually schizophrenia. And it's about the same, maybe 25% over if you look at 5-year follow-up. But most of them don't go on. Now, most of them do develop other kind of disorders or have significant disability. And some of them, the symptoms, just as the brain grows out of many seizure disorders, kids have seizures, they're seizure disorders that you just grow out of. Some people just grow out of these kind of hallucinations as their brains continue to develop. So my working model for psychosis symptom progression is, I think that environmental adversity, so this is my current work. So adverse childhood experiences and traumatic stressful events, sleep and circadian rhythm disruption, and genetic liability. So there's a polygenic risk score for schizophrenia, lead to high inflammation and oxidative stress. These are some markers that have been shown to be elevated in schizophrenia: IL-1 beta, IL-6, and F2 isoprostanes is a measure of oxidative stress. Which leads to dysregulated synaptic pruning during neurodevelopment, which leads to synaptic psychosis symptom progression. And so like I said, typically grants progress from the T32 or postdoctoral phase to KL2, which is a mentored research award. The KL2 is like a shorter version. My KL2 is on sleep. Frankie Achman is on this call right now. He's helping me analyze the data currently. We can talk more about that, but it's essentially kind of, we're still analyzing the data. We'll submit the abstract to ACAP, the annual meeting of ACAP, which is due February 15th. So don't forget to submit your abstracts. But it also includes a randomized controlled trial. So we measure sleep. So the patient population, P, is 11 to 30 years old. And they had to be patients that we were mostly recruited from CHOP, Penn, or a member of the surrounding community. And they had to have psychosis symptoms. So they had to at least have one CYPS positive symptom more than two, or diagnosis of a threshold psychotic disorder. And then they had to have at least mild sleep difficulties on G1. So we measured their baseline symptoms for a week, and then we randomized them to 2 weeks of either pill placebo or melatonin 5 to 10 milligrams. And then we measured, the outcome was actigraph measure. So actigraph is like a Fitbit, or it's sometimes called an accelerometer, clinician rated reports, self-reports of sleep and sleep diaries, and circadian rhythm, which is just the internal clock. So it's not just sleep, but when you're most active during the day too, and what time you go to sleep. So it's not just how much sleep you get, but what time do you go to sleep? Is that time consistent throughout the day? So that's circadian rhythm. Like I said, we're analyzing the data. It also looked at kind of immune activation and oxidative stress. This is one of the graphs. So it said under review, but it was recently accepted for publication. And essentially, I did a meta-analysis on all of the studies that have looked at pediatric psychosis, both subthreshold and threshold psychosis, and whether or not there were any abnormalities. So like I said, in the adult literature, it's pretty clear that both markers of oxidative stress and inflammation are elevated. But in the 38 studies that we reviewed, we found that CRP, or C-reactive protein, was elevated. IL-6, neutrophil to lymphocyte ratio, tumor necrosis factor, and total white blood cell were elevated in patients with threshold psychotic disorders compared to those without. But we didn't find, the data on oxidative stress was too heterogeneous to really interpret clearly, which is why I'm working on a current study to help elucidate that. But in the adult literature, there's a clear increase in oxidative stress. So this is a forest plot. So 0 is the middle, and as you see, total antioxidant content it's higher in controls. So controls have more antioxidants when you look at their blood than first episode psychosis. So that's one. So those are, I talked about circadian rhythm, oxidative stress, and inflammation. And then I currently have a grant looking at adversity, immune activation, and oxidative stress. We'll talk about the specific aims, but my mission is clinical research, and to really understand the basic mechanisms of psychosis in order to develop evidence-based and biologically targeted interventions for young people. And we learn PICO, patients, interventions, comparisons, outcomes, and time course. And we'll become into that studying the early phases of psychosis may help us understand biological mechanisms underlying schizophrenia. And I intentionally didn't talk about, I guess I talked a little bit at the front end about, and I'll exit out of this and stop sharing my screen, and we'll actually, you know what? Yeah. I will stop sharing my screen now. And I'll say, I intentionally didn't talk about, how race that much. I have written a few papers about race, but I think broadly speaking, I could talk more about how race is really influenced by trajectory. I think it's important to have clinician researchers of diverse backgrounds, one, who do research on health disparities by diverse people, right? So that's important. And it's also important for folks of diverse backgrounds to do research that focuses on other issues, because I think science and medical and health breakthroughs are ideally generalizable to under-resourced and minority communities. And I think folks from those communities have a very specific lens through which they see these issues. It's happened multiple times in my research group, which of course I'm the only Black person in, where basic things that, at least they seem very basic to me, because Philadelphia is 40% Black, are not basic to the folks in the room. And also vice versa. Things that seem like really intuitive to folks who grew up in different cultures is not at all. I've learned this many times. Continue to learn. Folks, we speak the same language, but sometimes we use words differently. In the first episode Psychosis program, literally we have team meetings twice a week, and one of the teenagers came in after being psychotic. He was like, "Yeah, I got a couple of bodies," and like no one else on the team knew what a couple, well, there's a black person on the team. There's what we have and she was like, oh yeah, we both knew what it meant, but like they were white. They are white. They didn't know what that meant. Like most people, I can't imagine anywhere people where I grew up not knowing what having a couple bodies on you meant. It means that you've like killed a couple people. Now, and when he said that, I was like, he ain't killed nobody. He ain't killed nobody. I know that for a fact. He's just like, he hasn't done it. But like, or similarly, like, I came up with one of my mentors at one point. Like, they didn't know what murked meant, which means to like kill. That person got murked. But you can also, I would say like black slang is, or Black American slang is very, it's really challenging to learn if you didn't grow up in it because folks use it in both like positive and negative ways. So you could say that person got murked, like he was murdered or killed. You can also say, oh, he murked that, like he did a really good job on that dunk or assignment. And so like if you don't know, it's like very nuanced, and even how you conjugate things. So like, and I didn't realize that there were all these rules until like I don't know, my sister explained to me like black vernacular English, like there actually are grammatical rules. So like he be frontin' is very different than he frontin'. Well, slightly different. So if you say he be frontin', that typically implies that he like often pretends to be something that he's not, like puts on a front or a facade. If you say he frontin' now, right, like, or he frontin', that assumes like, that implies that he's putting on a facade right now. So how you conjugate, but you would never say, anyway, how you conjugate the verb like incorrectly is like has meaning, and ultimately, kind of when I talked about this with my team, these things with my team, it's important to just have like cultural humility, right? Like if you don't understand something, ask. Definitely don't try to speak like them because someone did this already. Like when you don't really know how to do it, like it just seems like corny, or like because there's like an accent to it. Like if you don't do it correctly, there's an accent. Unless you're doing it trying to be cool, like I'm an old dude trying to be cool and hip. But anyway, so I think clinically it comes into play me being black, just culturally and language wise, and I think that sometimes I use it to build rapport with my patients, and I'm also gay, so I put rainbow flags on my office door at Penn where I do research, and I also put like rainbow is because it was really important to me when I was a teenager and even in college to see those rainbow flags. It was a safe space. Now I think it means less now, but still, I make sure to display that. And I make sure to, well, now I started making sure to say it. Like, I don't have to say I'm black. So I never, right, people see that I'm black. Whether or not people can tell if I'm gay, I don't know. So I think that, which is different, which is, we could talk about intersectionality later if you all want to. And then in terms of my research, the main thing, the way that it's affected me is that, I had a black, there's one black, I did my training at Yale, there's one black tenure professor at the Yale Child Studies Center, and he was like, I met him like my first year, second year, and he was like, Jerome, you're not gonna, I was so excited, I was like, maybe you can mentor me. He's like, Jerome, you're not gonna find a black mentor at Yale. If you're looking for a black mentor, you won't find one. And it was just and really, so I've never had a black research mentor, like someone who writes research grants as a principal investigator. Here, at CHOP, our department chair is a clinician, so she does a lot of scholarly and academic work. But in terms of first author, data-driven papers, or like writing grants as a principal investigator, it's really, really rare to find that, not even just in psychiatry, but like across the entire hospital system. And so in terms of mentoring, the thing that he said, which is very useful for me, is that what's important. Yeah, I think, yeah. The important thing is to understand that your mentor doesn't have to match you like racially. You can get that mentoring from other folks. It matters that you get along with one another, at least in the early stages, so that you can work together and that you have a good open relationship. And also, yeah, that's the main thing, right? Like, and their research goals align with yours. So whether, so right now my mentor is Raquel Gore, who she's an expert in schizophrenia research. And so like she's white, old lady Jewish or from Israel. And so, but our missions align in terms of improving outcomes in patients with schizophrenia. And I think the other way that it really affects me is that I chose to live in Philly, live in cities where there's a plurality of Black people. So I have like this cutoff in my head. I don't want to move. I'd have to have a really good reason to move to a city that's less than 20% Black. So, you know, I think Philly's 40% Black, 35% white, and 10% Asian and 15% Hispanic. And that's because for me, it's really important to give back to the culture and community that raised me. I think it's also a community where about 1 in 5 folks that I think I know, live under the federal poverty level, which is about $15,000 for an individual or $30,000 for a family of 4. And I think most Black Americans, so 80% of Black folks in this country are descendants of slavery survivors like me. And most of us are like at most 1 generation away from poverty, maybe 2. And so I think that it is I grew up hanging out in poor places, both rurally on my dad's side of the family, like trailer parks and all that stuff, and urban, like in cities. So I think that it really in our research group, it has become people know when I'm on a call, they always say it's important to give back because that is what I say all the time. And that really comes from both me having a loved one with schizophrenia, but also knowing that we're treating a predominantly Black or plurality Black community, which means, and you can give back, it doesn't have to be monetarily, but I do try to get subject reimbursements for clinical research up. But it can also be education. So we do education outreach groups. We giving folks meaning. Like, so it's not just enough to say, oh, well, we're including Black people in our study, so we're giving back to the Black population. Nah, you need to, that is one thing, but you also need to have a bi-directional communication with the community that you are doing work in and make, at least as far as I believe. And so we didn't get, I'll just do one quick tour of I want y'all to see, just go to the ACAP website. We can send the slides out after this, but I do want to show folks NIHreporter.gov really, really quickly because it really helps folks find where research is happening at their institutions. So I will put in, you can see my screen, right? So this is the ACAP website that has all these different awards for residents and early career psychiatrists, right? The ACAP Pilot Award, and has the deadline. So usually these deadlines happen every year. So you should write down awards that you're thinking about applying to, so you can be prepared and get your letters of recommendation. So maybe in July 17th, 2023. So it's probably going to come up around July 17th of 2024 next year. So when you want to, or this year rather. So you can get ready now. The other thing is I said NIH Reporter. So if you could Google NIH Reporter, I'll just Google it for, so you can see that you can just Google NIH Reporter. All right, so it's a requirement because all of NIH grants come from the federal government, so they have to show. These are, so if you look up University of Pennsylvania, for instance, search, it'll show you all the different grants that are happening now. And you can sort it by fiscal year. If you did University of Pennsylvania, let's see, Psychosis. These are all the different Psychosis grants. So this one is by my mentor, Raquel Gore. David Rolfe is also in our group. So you can see and these are happening now, right? So these are grants that are ongoing right now. And so it's really useful. So if you're interested in something at your institution, or maybe at an institution that you're not at, but is in your city or in your area, and you'd like to rotate with them or do research with them, I think that is NIH Reporter is a great source of information. And with that, I only gave you 7 minutes for questions, and I apologize for that. So I will stop sharing and open it up for questions. It's kind of a whirlwind. Any questions?
Feel free to type in your questions or just raise your hand and then you can talk too.
If not, I will go to jcap.org and show y'all that.
I have a question for you,
Yeah.
Dr. Taylor, but first, I just want to thank you so much for coming and sharing your research and your trajectory and your passion with us tonight. My name is Ty West. I'm a PGY2 resident at Ocean University Medical Center. It's one of the Hackensack hospitals, but a Penn alum. And I really have been diving into research to the extent I can in residency. I don't have a background in coding, but I am passionate about, my current interests are like include culturally inclusive innovations in group therapy, including the use of yoga and music therapy. Would love to continue that in CAP fellowship. Also medical education projects that I'm working on. But I guess my big question for you, and you have, you probably have a much more robust background in coding and statistics. I came into this, having a couple of undergrad stat classes under my belt many years ago. Where would I'm working with a biostatistician. He's helping me code a little bit in R, but I feel like such a novice. Where do you start?
Yeah. Okay. So this is a great question. And I used to code myself. And really, the first project that I stopped coding myself was or got a statistical consultant was relatively recently. I think it is important to code for me doing clinical research and also you, because with the type of research that you want to do, because it helps you understand the data. So Frankie's on the call. Like, it's really important to visualize data. There is a great book. It's on my shelf right here. You can Google it. This is an older version, but it's called like Intuitive Biostatistics that I use that I learned at the CDC. But I really think you do need a year of research to focus on, to focus on like understanding data. It could be T32 training. It could be a master's in epidemiology, but because to make an impact and publish your data, which if you don't publish it, then in like a peer-reviewed journal, then that means that other institutions and other researchers and other clinicians can't build on your data or build on what you did. So even if you present an abstract, it's just an abstract one time. It didn't go through the rigorous peer review process. So I would say you just, you can try to find a T32 program. I would talk to kind of mentors at your institution. You can and link up with someone who's done research before at your institution is really important. And it doesn't have to be quantitative data. There are also other types of data but I don't know how to analyze them, like qualitative data analysis. I've never done that before. But so, I mean, I would really say it does take time to learn, just like you invested a lot of time in becoming a physician and a psychiatrist. I think you do need at least probably a year of time to focus on research. And it could be even like a year, you probably do like 10 or 20% of clinical, or ideally like none during that year. But that's what I don't have any quick, I don't know if other folks have advice for how to get started.
That's super helpful. Thank you so much. And do you think that T32 training could be done during a fellowship, or should it be kind of your year as a junior attending where you try and
Lord. So yeah, I mean, there are a few programs where like at Harvard, at Yale, Colorado has one where you apply to it. Like, so there are research tracks that you apply to. And in those research tracks, they have T32 embedded in them. So that's how your research time is paid for. Usually, honestly, I mean, to get on those research tracks, you at least need like a co-author publication, and even most folks like me, I took a year. Like, I don't know anybody. I know one person who was accepted to kind of like one of those research track programs that integrated clinical and research, who didn't take any time out for research, which is also like meaning they didn't have an MD, PhD, or they didn't like do a gap year where they focused on research, or so they're pretty competitive programs. So, but if you're in child psychiatrist, like we're always looking for folks at Penn to do it. The problem is that it requires you to take a pay cut, like 80 grand I got paid, or and that's like if I did like 10% clinical. So like for that year, you take a big pay cut, which, you know, if you come from a disadvantaged background, or you know, it can be harder to do. But
I'm lucky enough to have a husband who's working, so
yeah, take time off. And
no, I would
out.
love to talk to you about that because I would love to stay in the area. So I'll
Give me an email.
mail you.
Thank you. Yeah, it was very nice meeting you, Ty, and also
Lovely
Daniel.
lovely to meet you too, Dr. Taylor. Thanks so much.
Call me Jerome. Yeah, but thank you. I appreciate
Will
it.
do, Jerome.
I think we have time for one more question, if anyone wants to speak up.
Oh, and there's a workshop survey. It looks like you put it in the chat, Sammy, right?
Yeah. So I did put a workshop survey down. People could fill it out, so we have more feedback about these series.
Oh, I didn't go to the black and white. Well, you saw us half and half. Did anyone was anybody able to see, like, who saw like blue and black and blue? Was anyone still on here? Like the dress that was okay, Jordan. Is there any way that you saw like it white and gold?
No, ever since the picture has come out, like I've never seen white and gold ever.
Never. Okay.
So I am one of the few people that has seen both.
Yeah, some people can see both. Yes, like I've seen maybe 1 out of 20 people. I don't know.
Tonight it was just blue and black, but I have seen white and gold, so I like believe that it can happen.
No, it can. So there's an auditory one, and when I'm really sleepy, I think I'm not sure if this is. I'm just making this, but it's like Yanni versus I forget what the other one is. But it changes for me. Like it changed from day to day, like between days. So. But yeah, usually I can only hear one at a time though. Some people can hear both, or it seems blurred. But so anyway, normalize that experience of you know, we can all experience it when we're tired or stressed, and be kind to yourselves. And thank you for your attention at 8 p.m. well, at least Eastern time. I really appreciate it, and don't hesitate to reach out.
Yeah, so thank you again, Dr. Taylor, for spending time with us today. It was a very enlightening and inspiring session, and I'm sure there will be plenty of mentees reaching out to learn more from you. And thank you everyone for joining us. And remember to mark your calendars for the next upcoming session on Thursday, February 15th. We'll be featuring Dr. Wanjiku Jirogi. So have
There's also
good...
a chop and
yeah, have a good evening, everyone.
Night, y'all.